Morning, everyone. So it's 7:30. So welcome to Cardiology Rounds. It's with pleasure I introduce one of our cardiac imaging fellows, Amir Aker, who hails from Israel. And he's only been here since July, and already I'm happy to announce he's a new father. Number one. Number two, he's working on 2 papers. And number three, he volunteered for rounds despite his busy schedule. So Amir is going to teach us about how we can use CT to guide primary prevention. Amir.
Morning, everyone. Thank you, Dr. Chow, for the kind introduction. So there's a lot to talk when it comes to atherosclerosis and primary prevention. And it's been a long road traveled. But what if all we know is only the tip of an iceberg? So our agenda today is going to be about some epidemiology, risk stratification. We're going to overview a little bit on atherosclerosis and pathophysiology. We're going to talk about calcium scoring and plaque characterization, some of the guidelines. I'm not going to include in my talk about radiation exposure. However, it's an important consideration when we are CT, just to keep it in mind. First of all, I want to thank the Heart Institute for offering such a great training program, and Dr. Chow for making all this possible. So if we take a look at the global burden of cardiovascular disease, ischemic heart disease is actually one of the most common causes of deaths globally. And it's responsible for more than 9 million deaths a year. And if we take a look at the forecast for 2050, we're heading in the wrong direction unless we adopt some preventive measures. In fact, if we take a look, it's expected to rise about 30 or 40%. Unless we move our conception from looking for ischemia, looking for atheroma. And in our practice, everything comes down to money. So if we take a look at the cost of managing coronary heart disease from this nice paper published last year, we can see that, even back in 2020, the management for our disease cost about 260 billion US dollars, and it's expected to double by 2050. So the development of cost-effective interventions to prevent cardiovascular disease, it should be a public health priority. In order to do that, we can apply all the preventive measures at 4 levels. First of all, we can apply that on the general population by understanding who is the population at risk. This can be performed by using data on family history, lifestyle, biology, and understanding genomics. We can apply that also on individuals at risk. So we can improve our risk screening strategies by using non-invasive imaging, biomarkers, and algorithmic models. Think about implementing AI in this field. Also in patients with known atherosclerosis by improving the imaging modalities, by using biomarkers, angiography, and the intracoronary assessment. And also the same concept applies also to the acute settings, like think about patients who present with a STEMI, like shifting the concept of door to balloon to first medical contact to balloon by improving our speed and passing the wire through. So if we take a look at the prevalence of coronary heart disease by age, it's well established that it increases with age. But what's concerning, if we take a look, it also exists in very young patients, even less than 40. And this was also proven in postmortem data. In this study, they were able just to prove that there is atherosclerosis even at very young age. And when we have risk factors, this prevalence of atherosclerosis becomes more steep in terms of prevalence and volume. So it's just important to be aware of the risk factors and the synergistic contribution of these risk factors on the prevalence and the incidence of high volume atherosclerosis. So the guidelines now recommend actually the use of risk prediction models to estimate the annual cardiovascular risk. However, even the Canadian guidelines advocate for the use of Framingham risk score. However, it underperforms in ethnic minorities. It lacks the dynamic changes and risk factors, and it over relies on age. Newer scores, however, like the score 2 from the ESC, actually included more risk factors, and it's adjusted for age and for regions. It's a newer score. We have it like adopted also for older age. We have the score 2 OP and the score 2 diabetes that can actually predict risk. Or I'd say same thing, they have some major limitations because they don't include data on medication use, family history, and all the list you see here. And also they do not include data regarding the chronic inflammatory states. Okay, sorry. So in order to treat our patients better, we need to shift the focus from focusing on the high-risk groups, just to apply all the screening methods on the broader general population. And we need to be aware of the concept of subclinical atherosclerosis, which actually, as the name says, it's the presence of atherosclerosis in one of more arterial areas in the absence of any signs, symptoms, or events related to that atherosclerotic plaque. It's something that has been described even 500 years ago by Leonardo da Vinci, as you see here, as vessels in the elderly through the thickenings of the tunics restrict the transit of blood. So it's something that's well known. And even since the 90s, key developments in non-invasive imaging have shifted toward the focus towards the detection of underlying pathology of the atheroma. So in order to treat better this disease, we must understand, first of all, the composition of the plaque. So we have the fibrous cap and the lipid-rich necrotic core. And we must always remember that it's a dynamic disease. So it's a wide spectrum of disease, and it's very dynamic and interchangeable. For example, if we have mild disease, it can become even in 1 or 2 years more severe, and it can also regress backwards if we treat it well. I'll talk about it later. So it's a wide spectrum of disease. We can have a thin cap, fibroatheroma. We can have, as you see in the middle, a ruptured plaque that healed, and we have the thick cap fibroatheroma, which is a more stable disease usually. This is also reflected by beautiful images from if we take a look at the OCT pictures, actually show the same images I showed before, just in OCT. And by using OCT, we can see also some macrophages when they have rupture or bending rupture. So it's important also for just to have an idea of the risk we should expect. So the development of atherosclerosis actually comes through 2 processes. First, we can have the intimal xanthoma, which develops the fibrous cape, and then can become thick, which ruptures. And these are the majority of our patients who present with non-STEMI and STEMI, if the whole vessel is occluded. Then we have the slower process, which is actually an intimal thickening, which can get eroded and give us also some events. So our mission is just to discover atherosclerosis early, understand it fully, and act to prevent events when it's still silent. In order to do that, we should track down the best available evidence, integrate it, and then evaluate the performance of these measures. If we take a look at the yield of elective angiography, we can see that actually the yield for obstructive coronary disease is relatively low. Only 1/3 of patients who are treated with angiography or referred for angiography are diagnosed with obstructive coronary disease. However, almost 40% of these patients have non-obstructive coronary disease, emphasizing what I said before. And the same thing, we can see it on CT data. Importantly, in this study, they were able to show that atherosclerosis actually exists even lower and intermediate risk groups. and it was found also in around 40% of patients. So it's an early indicator of increased cardiovascular death. In fact, this was shown by Dr. Chow back in 2010. He was able to show that patients with non-obstructive coronary disease actually have events. However, we see one patient that died without having any coronary disease. I was told by Dr. Chow that he died because of cancer. So what is really prime prevention? In order to apply that very well, we need to just optimize the balance because we can't treat everyone like empirically. So we should really identify the patient's risk. So the interventions we can take is by just acting on some behavioral and metabolic habits, like all the list you see on the left side of the screen. So good sleep, correct water intake, physical activity, healthy diet, and reducing weight. However, the Canadian guidelines have some statin indicating conditions. When we zoom in, we see that the Canadian guidelines actually recommend using statin for any angiographically detected atherosclerosis. So what's really the role of cardiac imaging? So in order to do that, we should be familiar with the tools we have by using cardiovascular imaging. First of all, we have the calcium score. We all use it in clinical practice. It's an established predictor of cardiac outcomes, and it's recommended as the initial test for patients with stable chest pain in the correct setting. And it's pathognomonic for atherosclerosis. In fact, some data in the literature advocate that patients who have calcium score more than 400, it's like having obstructive coronary disease. So calcium score actually correlates well with the amount of atheroma, and when we have calcified plaques, take a look at the area of our calcium score. Actually, it correlates. It increased the volume by 15.7 fold, according to this work from Jack. So we can use that also to apply, to decide who of the patients can benefit actually from aspirin. This was shown in the MESA study, where they were able to show that the net benefit of aspirin was shown in patients who have calcium score more than 100, in contrast to net harm of patients who had zero calcium score. And this, if we compare it to the PCE, the pooled cohort equations, actually, which is a risk score, it failed to identify these patients. So, the calcium score has an added value that should be applied in clinical practice. So one can ask, how long is this risk prediction is valid for? So we were able back home to show that it was just published by using a prospective trial, small study population though, but it was a prospective study of asymptomatic diabetics. We were able to show that the risk prediction of calcium score actually is sustained even after 17 years. Interestingly, we were able to show that patients with a calcium score of 0 had actually 0 MIs during all this period. So the guidelines actually adopt that as in the ACC at least, it's as a 2A indication. However, it's important to recognize the fact that it's an imperfect tool, because unfortunately it can miss non-calcified plaques. Indeed, these patients were reported in the MESA study to have some events, and this study they were able to show that almost a quarter of patients have actually non-obstructive coronary disease, even though by having a calcium score of 0. So we should see further and beyond the calcium score and use other tools by applying angiography, which can identify non-calcified and calcified plaques. And actually, we can use this data just to further risk stratify patients, and we can employ the prime prevention just to guide our therapy. So we can use that by identifying high-risk features, which is, we all are aware of that, but it's positive remodeling, the napkin ring sign, which is a very high risk feature, and the spotty calcifications and low attenuation, which is a reflection of the necrotic core of plaques. Indeed, if we have these features, they correlate very well also for for the probability of having a positive FR, so they correlate with ischemia too. In fact, FR positivity, according to this work from Jack, becomes more probable as the number of high-risk characteristics increases. So we can't talk about prime prevention without mentioning the Scott Hart trial, which actually favored cardiac CT as primary, as first line modality. Was an open label, multi-center parallel group trial, which randomized almost 4,000 patients with stable chest pain to standard care plus CT or standard care alone. And they were able to show a reduction in death and MI. Now one can wonder how can a non-invasive test actually reduce outcomes? So if we dig into the supplementary, we can see that almost 40% of patients had actual non-obstructive disease, and they got actually better preventive treatment, which actually is the main driver of the clinical events. However, it led at the first Scott to more invasive angiograms. So if you can see, actually patients who underwent CT had higher frequency of statin initiation and more antiplatelet therapies. The Scott Hart long-term, of the 10-year Scott Hart, they were able to show that the risk reduction and the events were still lower even after 10 years. And the difference in the invasive management was actually non-significant in 10 years. And we can note that the difference between the preventive measures, treatment, was sustained through the whole trial. Now we have the Scott Hart 2, actually is that's comparing the SI score, which is a 10-year risk prediction model, and guiding the versus CT and crime prevention, and it will end the recruitment 20.7. Another trial that work from Dr. Chow that showed a benefit from statin in patients with non-obstructive coronary disease. It was published, I think, in 2015. So we can see a significant difference between patients with baseline statin, if we compare that to in patients without the statin, we can see lower incidence of survival. However, this effect was not shown in patients without coronary disease. So it's important when we see that just to initiate statin therapy. So I'm going to present a case, very unusual. 41-year-old male with hypertension presents to the clinic with atypical chest pain. And he underwent a CT, which was reported to be normal. And then if we take a look at the calculation of his risk, it's actually less than 1%. And I can promise you, as I would do too, most of us would sign off this patient, right? We can't follow everyone, but I can tell you that this patient died from MI almost 2 years after the CT was performed. Now one can ask, how could that happen? This was my look when I saw this case. So it could be a lot of things, right? It could be embolic, SCAD, however, is a male. It could be a vasospasm, small plaques, because we know that the slice thickness we can go down to with the current scanners, it's like 0.6. So we can theoretically miss very small plaques. Artifacts can sometimes make things harder. And distal disease, we're not really good at identifying disease when the vessels are less than 1.5 millimeters. We can't think about microvascular disease, or it's very unusual to cause this significant events, or INOCA. So of course, these cases impact, they are powerful reminder of the limitations within our field, and the shifts our patient assurance from promise to commitment just to vigilant care. And we should not treat the disease, we should treat the whole patient. So there's an emerging role of the coronary inflammation. I mentioned that because I'm going to show you what happened in our case. It's a key factor in development and the progression of atherosclerosis. It can be measured by using the FAI. It's an index that actually takes into account local anatomy in the perivascular territory. It takes into account also biological factors, and it depends on the scan setting, but it differs, like if we have an acute MI or active inflammation, and it's useful also for guiding therapy. Its role was proven first in the CRISP CD trial, which which showed actually that patients with an attenuation of more than 70.1 had high risk for mortality and ACS. So back to our patient. So the authors of this case actually retrospectively analyzed the CT, and they showed that actually his FEI index was abnormal, and they were able to reclassify his risk up to 7%. So it's just important to be. It supports our notion that coronary inflammation actually develop way before the actual plaque. Before we see the actual plaque on CT. So it's very important just to keep it in mind. We have some trials to support this theory. Of course, the Colco trial, we're all aware of this. It actually reduced events after MI, and in stable patients, it was also shown to be effective in the local 2 trial. However, some trials like the CANTAS evaluating canakinumab failed to do so, and methotrexate actually also was not effective in reducing events. This is a nice paper from Dr. Boxar and Dr. Greenlands actually that summarized it all. However, if we take a look at this flow chart, we can note that we can use actually the CRP for guiding our therapy when it's high, especially like patients with chronic kidney disease. It can be used as a clue that this patient might have a chronic inflammation, and then we can give colchicine. It's a good thing just to keep in mind. So we need overall just to evaluate multiple aspects of cardiac CT, including plaque burden, the composition of plaque, and of course, if we have access to the evaluation of inflammation, it's key. A new concept I'm going to talk about now is that if we become good enough in identifying these patients, we can apply therapy just to stop the progression of plaque, and even we can reverse it. So the plaque regression concept was actually shown in the Pacman AMI trial, where they took patients with MI and they evaluated the non-culprit lesions. And they were able to show that if we apply high statin, high potency statin therapy, actually they were able to reduce the plaque volume. We can see it also here. So it has 2 main impacts. The first one is the reduction in plaque volume. You can see in the chemogram, which actually reflects the necrotic core of plaques. And also, if we take a look at this, the OCT images, we can see that they were able just to show that statins actually increase the fibroscape thickness, means that it stabilizes plaques. Was shown in a couple more trials of IVUS. One important trial actually they use in this one a moderate potency statin, which is the pitavastatin. They were able to show the same thing. It's a reduction in non-calcified plaque volumes. This was shown also in the paradigm study by using CT. So they were able to show the same thing. Basically reduction in plaque volume, but importantly in calcified plaques, it increased actually the calcium score of these plaques. It means that it did stabilize these plaque. So the guidelines now, the EC guidelines recommend CT as a first, like a class 1 indication. In the ACC, it's still 2A, but I guess I believe it's gonna change in the future. And the NICE guidelines were took to the extreme, and they now recommend CT as a first line management for everyone with chest pain. This summarizes what I just said. So it performs best in patients with low to moderate risk for ACS. So we can use that always. Now, what's waiting for us in the future? We have a new player in game. So it's the photon counting CT, which actually it's a different scanner. It actually converts the X-ray photons into measurable charge clouds, which actually, it takes the X-rays and it just converts them into electrical signal, which can give us high resolution images. If we take a look at the state piece here in the right side on the screen, you can see on the difference between the traditional CT versus the new photon counting. So it can improve visualization of the cardiac anatomy and the myocardial tissue. It can be applied in different fields in the cardiovascular imaging. So it can potentially reduce the rates of downstream testing and improves diagnosis and treatment, ultimately improve some clinical outcomes. One of the main limitations of CT is heavy calcification. So we can see the difference between on the right of the screen. By using the traditional CT, we can see the limitation when we have heavy calcification versus that photon counting on the left side of the screen. And these are some images I took from Dr. Filippo Cadamartiri, which is in Naples, Cell Lab, Italia. So they were able just to, it shows how it can detect really small plaques that can be potentially missed by using the traditional CT. Even in patients with stents, think about applying this in patients with stents, like it's a huge limitation, but we can show it can show us like very high resolution images, and we can detect even a small amount of instant restenosis. And also, if you take a look at, because as I said, one of the limitations, the the healthcare costs and the burden. So it can actually potentially reduce the costs of the management to our patients when compared to the traditional CT. It can reduce the downstream testing costs by 1/3. So five key takeaways from what I said. So just keep in mind that as the atherosclerosis, subclinical atherosclerosis, the missing link between risk factors and the actual cardiac events, and it's a call to action. Just when we see it, treat it because it's there to progress and it's there to stay. Cardiac CT is the gold standard for its detection. And the future, I think it's photon counting, which actually is gonna reshape all the definitions we know, and it's gonna change a lot in our management. And so we should keep in mind that we can integrate CT actually for risk stratification of patients in our daily practice. Thank you. So you can use, as I showed before, you can apply what the guidelines actually recommend. You can use risk stratification models. And if you have a patient like low, intermediate risk, and of course, it all depends on the history. Like if you have a typical angina, the risk is much higher. But if it's a low risk or intermediate risk patient, you can just use CT as a complementary tool. Of course, we can't scan everyone because, as I said, we need to keep in mind the cost effectiveness of these tools. We want to reduce the amount of radiation too, because sometimes we're dealing with very young patients. But if we apply the risk stratification models and we have high suspicion or some atherosclerosis, we can add the CTA as an additive tool to treat these patients. Yeah, so I mean, a lot of scores are out there. I mean, there's the prevent score, which is really good. The score 2 from the ESC, which have actually their own calculators. You can use it in clinic just to, because it's adjusted for age, and you can actually, it's very good for shared decision making because you can show actually the patient in which class he is, and you can show him his risk, and then you can like convince him to take the right therapy if he's questioning that. And then, of course, if you want to prove it further, you can just go with CT, and you can also add a lot of studies in the literature actually showed that if you combine calcium score with these risk prediction models, it improves the sensitivity of these risk scores. So yes, please.
Oh, let me make it a little bit difficult for you. Thanks, Amir. So, you say that using coronary CT scan for screening in a select population may be beneficial at changing your management, correct? So, what clinical endpoint are we changing other than applying the current standard of care to patients by identifying them a little bit earlier? So, what I mean by it is, if you look at any of the studies that you showed, none of them show any significant difference in hard clinical endpoints, mortality, looking at hospitalization for fatal MIs or, near fatal MIs. It's mostly revascularization early on. Those are the drivers for the, combined endpoints that they show. So why not just say, anybody with a waist circumference over this, with a family history of this, should be on a statin after the age of 40. I'm making this up as a mass screening thing. Why go through this process of, CT scans and radiation and try to identify them, especially if you're not changing much of a hard clinical endpoint?
Yeah, so I mean, if you remember the Scott trial showed it before, I mean, they were able to show that there is actually a reduction in our outcomes like mortality and MIs. I mean,
So
of
go
course,
back to the study, the Scott.
yeah, here. So yeah, this was for non-fatal MI. And so, I mean, if even after 10 years, they were able to show that there is a reduction, but of course, it's all driven by what you said. So it's of course what you just said, because
Correct.
actually these patients, I mean, of course, the CTA just guided the therapy because all of them had more statins.
Correct. So it's more identification of near, because if you go
Yeah.
back, you see within the first 6 months, you get a divergence of the curves, and
Yeah.
then they stay the same throughout the whole rest of the follow-up, right?
Yeah, yeah, correct. So it's a huge finding, and it's important for our practice. So I think it's important. We're saying basically basically the same thing because I think, I mean, it's just a tool to show. I mean, to identify these patients who have actually plaques, or like if a patient doesn't want to take a statin, you can send them to a calcium score. If he has still some calcifications, you can like show him that he needs that probably just to prevent these events. But I mean, of course, we can't scan everyone, but I mean, it's in these situations where you like question the need of this therapy because also we can't treat everyone empirically. So some studies are evaluating that, but it's not practical just to give statins for everyone without any risk.
I just think if you put everybody on statins after the age of 40, you'll get the same curves. I
Yeah,
don't think it'll make any
probably yes,
difference.
because, yeah, yeah, I believe it's true because if you take a look at this study I showed in the post-mortem data, so they analyzed the LED of everyone, the study, and this one. So basically, all of us here have plaques, if we want to put it right. So here you can see that, so we have the fatty streaks that actually are stable, And then we have the fibrocalcific, the fibroatheromas that actually begin to develop even before the age of 35. So everyone has plaques practically, and
So a patient comes to you, he's 45, he says, I want to have a coronary CT. I just want to know if there is anything in there. Would you offer them? Because that will be pretty much everybody that will come. I don't know.
yeah,
I'm an
yeah,
electrophysiologist and I see that request.
yeah. So some patients, a lot of them, we see it also in clinic, have like a strong family history, and yeah, I would send them to CT.
No other risk factors.
Because
They just say, I want it.
so now, I mean, we have improved our acquisition protocols, and the radiation amount is actually considered really low. And Dr. Chow can add about that too. So if he has a strong family history, I think it would help us just to manage them and treat them more intensively by proving that they actually have plaques, or by identifying the plaques, that the type of plaques they have actually.
Who would you not give a CT scan if they ask you? Let me put it the other way. Like I come to you and I say, I want a CT coronary. I want to know what my risk is.
35 pregnant women. Yeah, I mean, again, also it depends. So we also need to select our patients. So we should make the right call, because, as I said, we can't scan everyone.
Thanks for the great presentation. I just have two questions. One, you mentioned about statin with a calcium score of 100. We know aspirin for primary prevention, I think it came in 2020 when it's no longer a thing. When would you consider aspirin, depending on a degree of stenosis or a morphology of a plaque? And my other question, because in cath, we kind of know roughly when, but how much discrepancy CT versus cath, because sometimes we see that overcalling sometimes a lesion or kind of borderline. So those patients goes for an angiogram to better characterize the degree of stenosis.
Yeah, so I think basically, I mean, the spatial resolution of angiogram, I mean, it delineates. We sometimes see in the cath lab there's some irregularities, and these patients actually have plaques. However, in CT we can have more like plaque characterization, which actually can identify patients with high-risk plaques or high-risk features, which we can't see actually in the cath lab unless we use OCT or IVUS just to see, like, to further characterize these plaques. So I think basically each time we see plaques, even in the cath lab, even the guidelines advocate for that, we should treat these patients. So even if it's like near normal coronaries, we should treat them with statins. And I think also the aspirin, the risk of bleeding is low, because it falls into the category of subclinical atherosclerosis, and as I showed before, they do have risk for MI.
So can I just add a couple of comments? So Murda, just to your point, I'm a big believer of clinical risk scores still. It depends on where you practice. The US is very aggressive at using calcium scores in asymptomatic individuals just to risk stratify them. And whereas here, because of the limited resource, we typically don't do it. So we would send someone to CT, calcium score, or CCTA, I would say, with very kind of limited, like there's a small number of indications in an asymptomatic individual that I would send them. So I would traditionally send someone if for some reason I believe they need to be on statin therapy and they refused and said, prove it to me. Right. So that's typically the practice, I think, here at the Heart Institute. I think most of us believe that using clinical risk scores, if there's an indication for statin therapy, we just go ahead and start. There is the concept of de-escalation, where someone has a higher risk Framingham risk score, and then for some reason they get a calcium score and it's a 0. Some people have actually argued against medical therapy in those individuals. I won't say that's been widely adopted locally or nationally, but in some centers in the US, they actually practice de-escalation. So don't think we use it for screening in general, number one. And then in terms of aspirin therapy, just to answer, uh, in the US guidelines actually define thresholds of calcium score for initiation of aspirin. I would say that we have not adopted that locally. And if you look at the data, for sure, aspirin therapy reduces cardiovascular events, but increases bleeding. And when you take the two events together, basically you reach equivalence. So, you may save a heart attack, but then you increase subarachnoid hemorrhages. So in the end, I think locally we have not advocated for aspirin in primary prevention. For CT, in the cath lab, basically we would advocate for aspirin if there's an obstructive disease more than 50%. CT for sure overestimates lesions, but it depends on the reader, right? So there's reader bias to this. And based on our spatial resolution, we're only as good as categories, right? So we're good for, we can guesstimate a lesion between 50 and 69. But if you're to ask me, is it 50 or is it 55? I would tell you that we can't tell you the difference, and we can't tell the difference between 45 and 50. So based on CT data, extrapolating that, we're, let's say, accurate, we would still use the 50% threshold for aspirin therapy. Anything less than that, we would advocate for statin therapy. What I don't know, and the literature doesn't exist, is if we have high risk plaque. When we have these adverse plaque morphology where there's big lipid core, large lipid core, glycogen remodeling, that type of stuff. Should those patients be initiated on aspirin? I'd say there's no evidence. We still push statin therapy. We're participating in several trials now, locally using CT and potential plaque regression with the newer agents. I'm just trying to think which agent we're doing, but anyway, we're participating in a couple of large multi-center trials. And the concept is that, with PCSK9 inhibitors, we can reduce plaque burden. And they're using CT as a marker. But I just remind the audience that our spatial resolution is not super great. So, if we see plaque, there's probably lots of plaque. If we see no plaque, it doesn't absolve the patient of atherosclerosis because we can miss very small plaque volume. So, it is reassuring when we don't see plaque that, there's nothing huge, nothing high risk, but it would not necessarily absolve them of all risk. And that's why I'm still a big believer of clinical risk scores.
Sure you all heard that, but is there a role for carotid ultrasound in screening? Because this is a scarce resource, right? CT, we'd like to do more, but all the issues and barriers to CT have been mentioned. Carotid ultrasound is fairly simple to do and easy to train people.
Yeah, so it's a great question. And number one. Number two, for sure, carotid ultrasound has been shown to identify patients at risk of future cardiovascular events. I think that's the bottom line. They actually, I can't remember if it was the MESA group that did this, but they actually did a comparison of what was better. And calcium score won out. And I think in not only one trial, but multiple trials where they've looked at it. So it comes down to what's available. If I wanted to order a carotid ultrasound, I'm not even certain how I would do it here. But a calcium score in theory is easily accessible. We're starting to do more and more. It's interesting. Up until maybe 3 years ago, we've resisted doing calcium scores. We would do it if people requested, but we kind of shied away from it. I would say in the past 3 years, since all this data has come out, the requisitions have increased dramatically. So we're doing calcium scores more regularly. And I would say the primary referring population are family physicians.